A very good morning to one and all. Greetings from Dr. S.R. Chandrasekhar Institute of Speech and Hearing, Bangalore, Karnataka, India. My topic of presentation is dysphagia followed by cerebellar stroke, a case report. I, Prajna K. Udupa, am the presenting author and this paper is co-authored by Dr. V.S. Premalata. We authors want to disclose that there is no conflict of interest with regard to this presentation. Introduction. We all are aware that deglutition is a complex interplay between sensory and motor functions. Based on literature, the main areas involved in swallowing in healthy individuals include precentral gyrus, postcentral gyrus, supplementary motor area, insula, inferior frontal gyrus, cingulate gyrus, thalamus, and basal ganglia. Studies also indicate the role of cerebellum in swallowing as it monitors motor execution and its efficiency by comparing intended and executed acts and making finer adjustments to the motor plan. Anterior lobe with pronounced posterior lobe participation has been observed in the swallowing act. In the brainstem, medulla houses important structures of swallow called nucleus tractus solitari and nucleus ambiguus, which aid in oropharyngeal firing. Based on site of lesion studies, considering the etiological factors, posterior inferior cerebellar artery, a branch of vertebral artery, was the most commonly affected territory. It supplies the posterior lateral part of medulla and inferior part of cerebellum. This frequently causes impairment in the pharyngeal phase of swallowing. With this introduction, today I am presenting to you a case report of a 55-year male who had suffered from a stroke. Onset was with an episode of giddiness, pain in the back of his neck and twitches on the right cheek followed by unconsciousness. He had history of smoking, alcohol consumption and is a known case of cardiac disease, hypertension and diabetes. This stroke resulted in right-sided weakness and dysphagia. He had been fed exclusively via non-oral feeds, that is nasogastric tube, for the past 1.5 months. His neuroimaging report showed acute non-hemorrhagic infarct in right cerebellar hemisphere and right side of medulla oblongata. He was referred for evaluation and management of swallowing. Our assessment revealed no observed alteration in his cognitive or language functions. Oral peripheral mechanism examination and speech assessment revealed slight structural deviations of lips, jaw and soft palate at rest with restricted loudness and pitch variations. Speech intelligibility was minimally affected, resulting in mild dysarthria. Swallowing assessment included both subjective and objective assessment. Water swallow test with 5 ml quantity at room temperature was carried out to assess presence or absence of dysphagia. There was a cough post-swallow. He was also found to have reduced elevation of larynx with the 4-finger test. Test results of dysphagia outcome of severity scale DOSS indicated level 1. There is severe dysphagia as patient is on non-oral feed. Objective assessment. There was gurgly voice post-swallow on cervical auscultation and cough reflex revealed that the client is not at high risk of silent aspiration. Fees was performed. Right vocal cord paralysis with mild aspiration for liquids was evident. No aspiration and residue was observed during careful swallowing of minimum quantities of semi-solids. The diagnosis given was a person with pharyngeal dysphagia. The aim of dysphagia intervention was to have a safe and efficient swallow. The following techniques were followed. Compensatory strategies were incorporated to prevent symptoms of dysphagia, to maintain safety and to ensure adequate nutrition and hydration. Swallowing maneuvers were incorporated to alter swallowing physiology and to promote long-term changes. Respiratory and phonatory exercises were used to improve vocal cord adduction and to reduce the aspiration. Oromotor exercises were given as home practice to improve speech intelligibility. This table explains consistency of food introduced across 20 sessions. Initial sessions begin with dry swallow. Later, food presented graduated from semi-solid to purees to solid to thick liquid to thin liquid. Finally, when the client could swallow all the consistencies safely, with self-monitoring, the NG tube was removed. Progress was documented by videotaping every sessions with the client's consent. The client attended 20 sessions of swallowing therapy over a period of 1.5 months, approx 3 sessions per week. Therapy techniques involved gradual improving food intake of different food consistencies. As the frequency of oral feed increased, the tubal feeding was decreased. Rice tube was removed once the patient was able to swallow all consistencies of food without aspiration while following swallowing hygiene tips. Pre-therapy, the client came with a NG tube feeding with no oral feed. Post-therapy, the client could swallow all consistencies of food and liquid with approximate 5 ml of liquids or 5 grams of solid per trial. There was improved food propulsion and adequate food control. Meal duration was reportedly approx 20 minutes. No oral residue, gurgly voice post-swallow or aspiration observed. He gained approximately 2.5 kgs in 2 months. To conclude, post-stroke dysphagia is a very common sequel of acute stroke. Non-hemorrhagic strokes are less frequently associated with dysphagia. Predictors of dysphagia are location, size, extent of lesion, and its severity. The cerebellum coordinates with both cortical and brainstem circuits and forms the seat for feed-forward control. It controls timing, sequencing, and coordination for oral, lingual, and pharyngeal musculature. Cerebellar and medullary lesions can result in disturbances in the pharyngeal phase of swallowing. Secondary complications early after stroke can be prevented by traditional therapy. This is also used to improve affected swallowing controls and mechanics in the later stages. Management of dysphagia post-stroke, including intensive practice irrespective of etiology. Counseling plays an important role along with regular practice and motivation of the patient. This presentation highlighted the same. These are my references. Thank you.
Yeah, thank you very much for nice presentation. Now, let's open questions and comments from the audience. Do you have any questions? I think the patient has brainstem and also medulla damage, but isn't that dysphagia due to Wallenberg syndrome?
No, actually. So the predominant lesion was seen in the cerebellum. A small, minute, this thing was seen in the brainstem. So basically, we got the diagnosis predominant to the cerebellum, and we wanted to know whether the traditional will help the person in being better.
For example, did the patient have any other accompanying symptoms, gait, ataxia, dizziness, or hormonal signs?
Initially, when the client came to us, he came in the wheelchair. So the balance aspects and other things was he had weaknesses on one side also. That's when we couldn't say it is having a ataxic type of a thing, but speech, there was a mild dysarthria component being there. So holistic approach was given to the client to improve both the aspects, the speech as well as the swallowing aspects. And later on with the physiotherapy in hand, he improved better with the treatment.
Yeah, thank you very much. And one question from the audience. That's a great presentation. How long after the stroke did therapy begin?
Sorry, I didn't get the second part. Repeat.
Therapy.
The therapy was given for 1.5 months, and approximately 2 to 3 sessions he would come for therapy. And he was regular at practice. So, and his age was in 50s. So it is again a plus point for us in the management, I would say. And he recovered by then, and then we removed the NG tube by the end, and he was happily returning back to life.
So, any other questions? Yeah, thank you very much. Okay, the next speaker. Next speaker is Darian Ang from Science University. Are you ready?
Yeah, thank you. Thank you for your introduction. My name is Darian. I come from China. I come from the third political of Sun Yat-sen University. It's my great honor to have the opportunity to give the oral presentation here. Now, please play the video.
Hi everyone, nice to meet you. My name is An Delian. I will, instead of Zhang Yaowen and Tang Zhiming, give the oral presentation. I come from the Guangzhou, Guangdong province, China. My department is Rehabilitation Medicine, the third political hospital, Sun Yat-sen University. My oral presentation title is Change to Intermittent or Esophageal Tube Feeding, Elevated Pharyngeal Tube Infection Caused by Indwelling Nasogastric Tube, a case report. I have no interest with the list below. Our hospital built in 1971 is Hereby Clinic. After 50 years, our hospital has the 4 campuses. The total beds is more than 6,000. Our department in 2018 and 2019, it was ranked 10th in Fudan College Reputation rank list. The staff of our department, the Professor Dou Zulin, the chairman of Swallowing Disorders Special Committee of China Association of Rehabilitation Medicine, and he also the chairman of Guangdong Rehabilitation Medicine Association. We have the department specialized at dysphagia. We have the 35 dysphagia patients beds. There has the experienced and technological advanced team of swallowing rehabilitation. This is our Professor Dou, and this is our staff. In our department, there are 5 doctoral supervisors, 6 master supervisors. The total staff is 127. About our presentation is approximately 23% to 80% of patients with stroke have dysphagia, and feeding via indwelling nasogastric tube is widely used in these patients, especially patients with tracheostomy, and the feeding tube will associated complications include mucosal bleeding, tube infection, pneumonia, and acid regurgitation, but in the clinical work, the nurse can't see the associated complications with their eyes. In our department, we will give the dysphagia patient nutrition first. We will use the parenteral nutrition and enteral nutrition, and especially the very special method, non-invasive, intermittently include 4 methods: transnasal esophageal tube feeding and oral esophageal tube feeding, and transnasal gastric tube feeding and oral gastric tube feeding. This is used very frequently in our department, and we will use the different methods mixed together to give the before we assess or give the patient assessment. We will use the different methods to solve their problems. And intermittent feeding via mouth or nose to esophagus stomach. It refers to the technique of inserting the tube into the esophagus or stomach through their mouth or nose without leaving the tube in their stomach, and then pulling out the tube after feeding. This method is maintain normal physiological structures of the digestive tract. Although the complications of continuous gastric tube include mucosal ulcer, hip cup, reflex, aspiration pneumonia, and this method is simple, safe, non-invasive, and the feeding amount varies according to the patient's condition. And it is very easy to training for swallowing can be performed simultaneously. Swallowing reflex induced by stimulation to flex. Don't affect the parents and rehabilitation training. Better return to the society and family. In this case, the patient is 34 years old man. Was referred to the Department of Rehabilitation on 9 February 2020. He had stable bowel sense, clear consciousness, and cognitive impairment. And his weight is 37.8 kilometers, and BMI is 21.6, and voice is 1, and the RS 2002 is 5 point, and the Basel index is 0, and the most scores is 60, and the fibrotic bronchoscopy examination on 13 February 2020 showed epiglottis and left atrial tumefaction. The nasogastric tube entered the esophagus through the left perimyocinius and changed the nasogastric tube from indwelling to intermittent. The procedure of intermittent oral esophageal tube feeding is supplement material. The patient had no calcium omitting, dysphagia, or any other discomfort. We will see the intermittent feeding under the X-rays. This is the nutrition tube feeding tube from the mouth to the esophagus. And this is the nutrition plans, and this is the intermittent nutrition feeding materials. This is the milk, and this is the intermittent nutrition tube. We will administer 2,160 Tianka per day using total enteral nutrition based on his body weight. And we will the result is changed in tumor fraction of molecular epiglottic and ateronoid after intermittent also esophageal tube feeding. This is at the first week in our department. This is the 2 weeks, the second week, and this is 2 weeks ago. This is we will see that the edema relieved, and we will see that in our department the patient's body weight and BMI, hemoglobin, and cough by secretion aspiration, and the Maria secretion rating score, gastrointestinal tolerance voice is all improved. The patients recovered quickly in our department. And enduring nasogastric tube feeding may cause complication of reflex, increased secretions, and we will use the intermittent. This method is worthy of clinical application. Our department is the first in China to use the intermittent tube feeding for enteral nutrition support in patients with the post-stroke patients. In 2015, more than 36,500 times per year in our department. Welcome to Guangzhou to visit our hospital. That's all. Thank you.
Thank you.
Thank you very much for your wonderful presentations. Any questions? So you report on patient with an intermittent esophageal tube. So this is the first time I have heard of this. Is tumefaction common phenomenon in nasogastric tube feedings?
What?
Tumefaction.
I can't hear you. I can't hear you.
You means tumor formation. Tumor.
Yes.
Common phenomenon.
Common phenomenon.
Common phenomenon in nasogastric tube feedings.
Yeah.
So it is not malignant, is it?
It is very easier. We will use this method. It's different with the balloon dilatation, because in our department, the professor provide the new method to give the dysphagia patients. The new therapist is called balloon dilatation. But in our clinical work, the patients most is seriously dysphagia problems. They don't. They give the nutrition is at first and priorly. So we use the nasal tube have the many problems. And in 2016, 15, we use method to give the patients the clinical nursing care to give the nutrition. It's different with the balloon therapist. The balloon therapist use through the prefer to the first is through the nose, but in our clinical work we use through the mouth. We will use the mouth, close the mouth and the tongue movement, and the patient needed to swallow first, and then they will put the nutrition tube after. So it is very easier and safe. In one day we will put 5 to 6 times, and if the give the nutrition is enough, the total nutrition we will at first the serious dysphagia patients will can't swallow can't our feeding, and we use the nutrition tube totally. After give the therapist maybe it can part oral feeding, we will reduce the nutrition the amount of the nutrition calories.
I see. One question from the audience by Dr. Takashimori. The tube seemed to have a balloon. Do it always needed?
Yes. At the first time, because in China we have divided the nutrition tube is different with the balloon tube, but it at the first time we haven't designed the new nutrition tubes. It is we use the balloon tubes to give the patients the nutrition feeding, but now we have the serious dysphagia patients. Some patients have the reflux. We can't give the nutrition to the esophageal because it will reflux. So now we will use the another method. We use the nasal tube. We use the nasal tube give the nutrition tube. We will mix it together. We will give the assessment first. If the patient have no reflux and the esophageal is no camera and no cancer is safe, no reflux, and the patient's the gurgle reflux is not so strong, we will use the balloon tube to give the nutrition tube. If they have the reflux and some problem with their esophageals, we will use the nasal tube. Yeah.
Sorry, one more question. When we have a patient with swollen arthritis, we use a tube with a smaller diameter. I also see regions when interesting the nasogastric very often in the epipharynx. What is your experience?
my appearance about the method?
Probably from Dr. Michaela, Trappel Grand Tuva.
Yeah. The question is that about the appearance of the new equipment to give the patients the nutrition.
About regions.
Regions.
Region, yeah.
Region. Okay. In my research, I have under the you will see that I will put the tube under the VF, and we will see that the nutrition is fluid fast, and the low part of the esophageal is movement, and when we give the nutrition, we will ask the patient to swallow. When the patient swallow, the tongue will movement, and the esophageal and laryngeal and esophageal will movement. I think maybe the last we will use the low part of the esophageal movement to give the exercise. They can feel the food and the temperature of the food, and the movement is swallow down, and maybe will prove the top of the hair, the laryngeal recovery.
Yeah, thank you very much. Good job. Thank you very much.
Thank you. Thank you for
next.
Thank you for your attention. Thanks.
Thank you. So the next speaker is Dr. Karma.
Salmah.
Yeah. Are you ready?
Oh, yes. Thank you, Professor Shinchi. I'm Salmah Anim from Malaysia. I'm a rehabilitation physician. Thank you for the opportunity for me to share my experience in setting up a post-stroke dysphagia rehabilitation team in Malaysia. Please start my video. Good day, everyone. I am Dr. Salmah Anim from Sultan Ahmad Shah Medical Center at International Islamic University, Malaysia. I will be speaking on establishment of a post-stroke dysphagia rehabilitation service in an upper middle income nation. First of all, I would like to declare that I do not have any conflicts of interest to disclose. Post-stroke dysphagia rehabilitation is a key performance indicator for stroke management in Malaysia. From a local study conducted by Hamidun et al. In 2006, dysphagia is an independent predictor of mortality at 1 month post-stroke. However, in our country, multidisciplinary post-stroke dysphagia management is still not widely available due to scarcity of trained professionals, limited resources, and lack of awareness. Our hospital, Sultan Ahmad Shah Medical Center, is a university hospital established in 2016 with a 350-bedded capacity. Prior to 2019, rehabilitation medicine services were not available. As of currently, I am also still the only rehabilitation physician serving the hospital. Upon starting our neurorehabilitation service, we noticed a lack of coordinated dysphagia rehabilitation for stroke patients. From June to December 2020, 37 patients were referred to the rehabilitation medicine team for stroke rehabilitation. Out of this, 25 patients suffered from anterior or posterior circulation infarct, and 59% of patients scored moderate to severe stroke based on NIHSS score. Among patients referred to us, the prevalence of dysphagia was high at 57%. Patients who had more severe stroke, especially those with anterior circulation infarct or those with posterior circulation infarct, had more prevalence in post-stroke dysphagia. There was also significant morbidity whereby 7 patients had aspiration pneumonia and 2 patients deteriorated and required mechanical ventilation in the ICU. The most significant difference was that the length of stay for patients with post-stroke dysphagia doubled those without. The mean length of stay for patients with dysphagia was 10 days, whereby those without only stayed for 4.6 days. Therefore, this justified an urgent establishment of a coordinated post-stroke dysphagia rehabilitation service in our center. The aim of the service was to provide in the inpatient service was to provide early dysphagia screening and a structured and systematic dysphagia assessment and early rehabilitation, whereby for the outpatient service, we emphasize on establishing a specialized dysphagia rehabilitation clinic to enable stroke patients to be reviewed early. For the methodology, we initially focused on collaborating and networking between various disciplines, namely the physicians, ORL surgeons, speech language therapists, dentists, and dietitian. Later on, we collaborated with the nursing team and even undergraduate students to provide assistance in our dysphagia rehabilitation program. We also established a core stroke dysphagia rehabilitation team, which consists of rehabilitation medicine doctors, speech language pathologists with extensive training in dysphagia rehabilitation, and also physiotherapists, occupational therapists, and nurses. Secondly, we developed a referral pathway for post-stroke dysphagia management. For the inpatient referral, we emphasize on early dysphagia screening among stroke patients. Bedside screening were done using standardized assessment tools to ensure that systematic examination was done. Rehabilitation medical officers were trained in various aspects of dysphagia management so that they could lead the dysphagia inpatient rehabilitation program. The outpatient dysphagia rehabilitation clinic was established in March 2021, and patients were seen by the speech language pathologist within 2 weeks of discharge. We saw positive results for patients referred to us after the establishment of the stroke dysphagia rehabilitation service. From March to June 2021, 45 patients were referred for stroke rehabilitation, and 36% of these patients were identified to have post-stroke dysphagia. We saw an equal distribution between lacuna, anterior or posterior circulation infarcts for those affected with dysphagia. Patients were referred early to us, and the mean first contact was at day 2.5 of stroke admission. Assessment using the GAS score showed a mean score of 10 for patients referred to the team. Therefore, 44% of patients were able to be discharged with modified dysphagia diet and also early dysphagia rehabilitation. However, 56% of patients still required nasogastric tube feedings and were seen at the outpatient setting. There was a reduction of mean length of stay for post-stroke dysphagia patients, formerly from 10 days, and now the length of stay reduced to 4.4 days. Among those patients referred to the stroke rehabilitation team, there were no patients affected by aspiration pneumonia or those who required mechanical ventilation. So this was a success for us. The outpatient service, other than running the dysphagia rehabilitation clinic, we also expanded the service to include dysphagia rehabilitation component in stroke therapy care by physiotherapists and occupational therapists. The reduction in length of stay allowed a substantial saving in economic expenditure for inpatient stroke care. Aznida et al. Reported in 2012 that the cost of stroke inpatient admission in another Malaysian university hospital in 2010 averaged to 931 ringgit per day. So this was a significant achievement for our center. We also achieve reduction in morbidity with no post-stroke aspiration pneumonia and prevention of ICU admission. The coordination of dysphagia management also allowed for a successful transition to oral feeding among stroke patients referred to us. As a conclusion, the establishment of post-stroke dysphagia rehabilitation team has led to successful patient outcome and benefit for hospital management. A coordinated multidisciplinary approach tailored to local resources is key in ensuring success for post-stroke dysphagia management. We also received challenges from the COVID-19 pandemic, whereby there was a disruption in services due to travel restrictions and work from home order. I would like to take this opportunity to acknowledge the hospital director and head of the ORL HNS service for providing full support in the establishment of our post-stroke dysphagia rehabilitation program. With that, I thank you.
Dr. Salmah, thank you very much for great presentations. I agree that it is important to have a multidisciplinary approach to dysphagia, as you mentioned. So thank you very much. So discussion or some comments or questions? Yeah, so poor nutrition can also have had influence on stroke rehabilitation. So nutrition status is very important, I guess. How do you feel? How do you mean?
Yes, Professor, that was my main concern. Other than safety for discharge to prevent aspiration pneumonia, we found that our patients were neglected in nutrition and hydration, especially for the elderly. However, that would be an interesting data to collect in our center because in Malaysia, the geriatric population affected by a stroke is large. So concluding with the whole dysphagia summit, frailty and sarcopenic dysphagia is so relevant.
Yeah, thank you very much. And next questions has come from Dr. Takashimori. The length of hospital stay is shorter than in Japan. How do you continue rehabilitation after discharge? Yeah,
this is when we tabulated the data, this was very surprising to us as well. Apparently, we did what was conventional, basically education, providing materials via QR code, and also resources via the internet with links. Before discharge, we usually identified a caregiver that can be reliable and who is a bit tech savvy, and we use technology for the materials. Otherwise, I believe that we have been lucky because in Malaysia, I think in our center especially, we have patients with a good family support. Maybe that is also why the readmission and length of stay is successfully reduced.
Yeah, thank you very much. So we have to go to the next presentation. Thank you very much, Dr.
Thank you very much.
Yeah. The next speaker is Dr. Marta Arbaladwit. So are you ready? Marta,
yes, thank you, Professor. Thank you. Good morning. I am Marta Alvarez. I am a neurologist from Hospital de Mataró from Barcelona, Spain. Thank you for giving me the opportunity to present today with all of us. Our work was pre-recorded by my partner, Dr. Nascimento. But please, could you start the video?
Hello, my name is Whisz Nascimento, and today I will present our work, spontaneous swallowing frequency, nutritional and hydration status in patients with post-stroke with and without oropharyngeal dysphagia. Regarding this presentation, we have no conflict of interest to declare. Oropharyngeal dysphagia is a condition recognized by the World Health Organization. Dysphagia has an incidence of almost 48% in the acute phase of the stroke and a prevalence of up to 40% in the chronic phase. Also, severe complications is associated with dysphagia in this population, such as prolonged hospitalization, institutionalization after discharge, poor functional capacity, nutrition and respiratory impairments, and mortality. Spontaneous swallowing is a protective aerodigestive oligosynaptic brainstem reflex that contributes to the protection of the respiratory tract, since its reduction could lead to an increase in pharyngeal secretions and the risk of aspiration, whose primary triggers imply necessary peripheral stimulus, saliva. Normal swallowing requires the participation of a widely extended cerebral network with fine output motor commands occurring after activation of brainstem circuits in which the central pattern generators nuclei are involved. Little is known about saliva swallows mechanism. Very recently, our group has demonstrated a proportional and physiological decline on the swallowing spontaneous frequency with aging. Furthermore, it was observed a decrease in the spontaneous swallowing frequency in post-stroke patients. Previous studies reported that substance P concentration in sputum is reduced in elderly and post-stroke patients with aspiration pneumonia. Also, it was observed that a low concentration of substance P in saliva is a potential biomarker to monitor pharyngeal sensitivity in elderly patients with oropharyngeal dysphagia. Our aim with this study was to compare the spontaneous swallowing frequency, the salivary SPA concentration, the dehydration and nutritional status of post-stroke patients with or without oropharyngeal dysphagia. Here you can see our experimental design. In the morning, we collected blood and saliva samples. We performed the VVST, the mini nutritional assessment, and the bioimpedance. In the afternoon, we recorded the spontaneous swallowings and collected another saliva sample. Oropharyngeal dysphagia was assessed by VVST. We identified clinical signs of impaired efficacy, such as lip seal impairment, oropharyngeal residue, and episemio deglutition, and clinical signs of impaired safety, such as wet voice, cough, or oxygen desaturation. After the test, we selected the adequate bolus volume and viscosity for each patient, and also it's important to explain that VVST is a method with high sensitivity and specificity. Spontaneous swallowing frequency was measured with surface neck electromyography and accelerometry. After cleaning the skin with alcohol, electromyography electrodes were positioned over the suprahyoid muscles, while the omnidirectional accelerometer was placed over the cricothyroid cartilage. Spontaneous swallowing frequency was acquired during 10 minutes, and all participants were required to avoid body and head movements and talk during the experiment. Spontaneous swallowing were considered presented when the activity recorded on both the electromyography and the accelerometer channels was compatible with the typical neurophysiological swallow configuration and consistent with visual inspection. Spontaneous swallow rate was calculated as swallows per minute, and after detection of a swallow, we analyzed offline each one of them regarding the amplitude, duration, and area under the curve. Saliva samples were collected on mornings and afternoons. A salivate swab was placed under the tongue of the patient for 5 minutes. After the centrifugation, the clean sample was stored at minus 80 degrees until the determination of substance P by ELISA. Hydration status was measured by bioimpedance. Electrodes were placed on each hand and one pair on each ankle. The patient was lying or in a sitting position depending on their condition. The nutritional status was measured by mini nutritional assessment and blood analysis. The mini nutritional assessment was answered by the patient, the family, or caregiver, and the blood samples was collected before meals and within the care routine during the patient's admission. We included 45 acute patients in this study, and we observed that patients with dysphagia were older, had a higher NIH score, and a worse functional status at discharge. Also, there was no significant difference in terms of topography, lateralization, or the type of stroke. Regarding the swallowing assessment, 27 patients had oropharyngeal dysphagia and 40% of them impaired safety of swallow with liquid viscosity. Spontaneous swallowing frequency was reduced in half in post-stroke patients with oropharyngeal dysphagia, and for the electromyographic parameters, no significant difference were observed when compared both groups. No difference were found between groups for morning or afternoon saliva SP concentration. Patients with oropharyngeal dysphagia had a higher risk of malnourish, signs of intracellular dehydration, and a reduced albumin, prealbumin, lymphocytes, and total cholesterol serum values. In conclusion, oropharyngeal dysphagia is highly prevalent among acute post-stroke patients, with 40% presenting signs of impaired safety of swallow. Spontaneous swallow frequency is reduced to the half in post-stroke patients with oropharyngeal dysphagia, showing a severe impairment in the cortical and brainstem mechanism controlling deglutition. No statistical difference were found in this study regarding the levels of substance P in saliva. And finally, patients with post-stroke oropharyngeal dysphagia also present high prevalence of hydropenia and clinical and biochemical signs of poor nutritional status. Thank you very much for your attention.
Thank you very much for wonderful presentation. So Marta presented some interesting data. Now, comments from audience. So from me, it is well known that acute stroke is associated with a high rate of pneumonia. Does it any relationship with SSF?
We found that spontaneous swallowing frequency is reduced in patients with oropharyngeal dysphagia. And we thought, or hypothesis, is that the sensitivity deficit caused by stroke reduce the oropharyngeal sensitivity, and this way the SSF is reduced, leading to a more accumulating of oropharyngeal secretions, and this way an increase of the risk of pneumonia and aspiration.
So, and I know the substance P in the brain is related to the cough reflex, but it's the same for substance P in saliva?
Could you repeat, please? I didn't get the answer.
I know the substance P in the brain is related to the cough reflex. So, but is it the same for substance P in saliva?
Yeah. Previously studies have reported a reduced in substance P in concentration in saliva in patients with aspiration pneumonia and dysphagia. Yeah.
Wonderful. Thank you very much. Okay, we have to time to have to go to next presentation. Thank you very much, Monica.
Thank you. Thank you very much.
Dr. Ivy Chen, are you ready?
Yes, I'm ready.
Yes, please.
Thank you very much. Well, thank you very much for having me here in the second World Dysphagia Summit. It's my great pleasure to be speaking here with you all. Please start my video. Hello, everyone. First of all, I'd like to thank the organizing committee of the World Dysphagia Summit for having me here. My name is Ivy Chen from the University of Manchester, and I'm going to present on behalf of our team a systematic review and meta-analysis on pharmacological intervention for post-stroke dysphagia. We declare that there is no conflict of interest. Dysphagia is a common problem following stroke, affecting as much as 80% of the patients. Existing dysphagia treatment can be compensatory, for example, diet modifications, or rehabilitative, for example, oral motor exercises. However, the therapeutic potential of pharmacological intervention is relatively underexplored. On the right side, there is a list of drugs that have been identified to be potentially beneficial for dysphagia. These included the transient receptor potential TRP channel agonists, including TRPV1, TRPA1, TRPM8. Calcium blocking agents, dopamine D2 receptor antagonists, angiotensin converting enzyme ACE inhibitors, nitric oxide NO donors. The mechanisms of action of these drugs on swallowing is largely unknown. Here are some proposed mechanisms. The first one is through increasing the sensory inputs to the swallowing system by TRP channel agonists. The second one is by increasing the level of substance P, which is a neuropeptide known to be associated with cough reflex or swallowing reflex. And lastly, by treating the coexisting esophageal problems, the oropharyngeal functions may also be improved. In our systematic review, we searched 4 electronic databases from January 1970 to March 2021, and these are the keywords searched. 2 independent reviewers performed the literature research, data extraction, and the risk of bias assessments. And data synthesis was performed by 1 reviewer and then verified by another. We included randomized controlled trials in patients with post-stroke oropharyngeal dysphagia, and the oropharyngeal dysphagia was determined clinically or by validated self-report questionnaires. The intervention were pharmacological drugs versus placebo interventions or no interventions. Co-intervention were also accepted as long as the only difference between the 2 groups was the target drug. And the outcome measures were any measures related to swallowing functions. We excluded studies that were not RCTs and were not in English. And for studies that included patients with esophageal dysphagia only, we also excluded those. We also excluded studies that use non-validated subjective weighting of swallowing ability. And for the results, we identified 508 studies in total, and we excluded 24 full tests after screening. And then finally, we included 9 studies for our meta-analysis. The overall quality of studies was poor, considering the high performance bias in more than half of the studies and the high risk of attribution bias in approximately half of the studies. A total of 2,082 patients were included in all studies. We included 9 RCTs. 4 of them investigated the TRP channel agonists, including capsaicin and papain. 1 studied calcium blocking agent, nifedipine. 1 studied dopamine D2 receptor antagonist, metoclopramide. 2 studied ACE inhibitors, lisinopril, imidacloprid hydrochloride. 1 studied nitric oxide donor, glycerol trinitrate, GTN. And the outcome measures include severity rating of dysphagia, prevalence of silent aspiration, timing of swallowing events, and feeding route. This table shows the study characteristics of all the trials included in our meta-analysis. You can see that almost all trials studied the effect immediately post-treatment. Adverse events were reported with some drugs, including lisinopril. The study found that there were higher mortality rates in the treatment group than the control group. For nifedipine, the patients showed worsening of heart failure, flushing, and giddiness. And for GTN, patients reported a higher rate of headache and clinical hypotension. There were no serious adverse events or any adverse events for TRP channel agonists. Moving on to the effects of TRP channel agonists on swallowing. We found that the overall pooled effect size was medium and significant. For the other pharmacological agents, because there were 1 or 2 RCT for each drug class, so we analyzed them in a group. And the pooled effect size of these agents was non-significant. However, when you look at them separately, there were significant effects for nifedipine and metoclopramide, and both of them showed large effect size. But bear in mind that only 1 RCT were available for each of these drugs, so the results probably is not too representative for the efficacy of these drugs. In conclusion, overall, there is very limited evidence to support the efficacies of pharmacological interventions for post-stroke oropharyngeal dysphagia. Our meta-analysis found that capsaicin or papain may have beneficial effects for these patients compared to placebo interventions. However, the evidence for most other drugs are very limited and inconclusive. In the future, large-scale, multi-center clinical trials are warranted to fully explore their therapeutic effects on swallowing. This is the end of my presentation, and I thank you for listening, and I welcome any questions.
Yep. Thank you very much. Dr. Chen reported on systemic review and meta-analysis for pharmacological interventions for dysphagia. So any questions? Nice presentation, interesting. So from me, some drugs for hypertension are used in RCTs, but not for dysphagia, right?
Yeah. So, for example, GTN I think that's one of the drugs that's usually used for hypertension. But then the authors also looked at different outcomes following the drug, and they also evaluated the swallowing function, and they found this extra effect that was not intended for dysphagia originally.
Yeah, very nice, interesting presentation. So I am very sorry to have to limit the interesting discussion on this paper. So it's the time to close this session. The presentations were all very interesting. I look forward to your future activities. Thank you very much.
Thank you. Bye.
Thank you and bye-bye.